oncologists and other specialists involved in the care of people with cancer must do is first of all name the cancer, and we can only name it if we get a piece of tissue. There are different types of cancer and they behave differently and require different treatment approaches. So we have a saying in oncology that tissue is the issue, so we need tissue to be sent to a pathologist who can look at the cancer under the microscope and tell us what type it is and what other characteristics can they tell us about it. The second thing is to stage the cancer, and I'll talk more about this in a minute. Once we've got this information, a treatment plan can be developed. And the way we develop treatment plans in 2016 is usually working in teams of specialists where we all bring our skills and experience to bear. The person is presented, their situation is presented fairly anonymously, and we look at the pathology, we look at the staging investigations, and we give the referring doctor a suite of recommendations to take back to the person to say, well, this is what the meeting of the team suggested would be a reasonable treatment plan for you. It doesn't bind any party to that recommendation, but it's an incredibly valuable process because having other minds at work who are one step back from the person can lead to very, very useful suggestions. And reviewing the pathology and reviewing the x-rays can often unearth other things that can be a bit of a surprise that might make a major change to a person's treatment and outcome. So just quickly stepping through these, giving some illustrations. So under the microscope we've got two different types of cancer that can affect the bowel. The one on the left is a sort of fairly common type of cancer of the bowel, and on x-rays and looking into the bowel they can look exactly the same as a quite different type called a neuroendocrine tumour. Less common but markedly different in its behaviour and the treatments. So we really need to know what type of cancer we're dealing with so that we can devise the treatment that's appropriate. Staging of the cancer is, whoops, we've got a bit of musical background. Basically, staging is working out how far has it gone. So within the primary area, there can be 3 early stages, 1, 2 and 3, or A, B and C. And that really, this is an illustration of the staging of bowel cancer. It's probably a bit hard to see from the back of the room, but it's all about how far through the wall of the bowel has it gone, and has it spread through lymph channels to lymph glands in the neighbourhood. And stage 4 usually signifies that it's found in other organs of the body. So why would we bother staging a cancer? The stage is clearly related to the chances of the outcome. So this, when we oncologists consider groups of people, clearly one of the key things we're interested in and our patients are interested in is what are the chances of cure, what are the chances of survival. So this slide illustrates it could be any cancer, it doesn't matter which one really, but for each stage there's what we call a survival curve. So you'll be able to see that for a stage 1 cancer, nearly 100% of people are alive, say 60 months or 5 years down the track. And as we step through the stages, the number of people surviving is less. So this provides people with very useful prognostic information so that they can plan their lives, so that they can know whether a particular treatment is worth it or not. So that's very, very useful information for the person and their advisors. Clearly, what we're trying to do through research is get more people in the early stages through screening and early diagnosis, because if you're starting out on one of the higher curves, then life's prospect is a lot rosier. But also, as well as trying to shift the numbers of people up the curves, we're trying to shift the curves up through different treatments. So we're trying to improve the outcome for every stage through research.